Thanks for listening to the Granite List Live. Today's episode is brought to you by Connect Healthcare Collaboration, where benefits marketing meets clinical advocacy to drive effective employee engagement. This is the Granite List Live, where we explore all things human capital and employee benefits related. I'm your host, Sally Pace, and today I'm joined by two of my most favorite people from Prism Health Group, Ryan Rice and Jake Goll. We're going to be talking about Spectra, their new clinical performance engine. But before we get there, guys, do you mind giving just a little bit of your background and what Prism as an entity does?
Absolutely, Sally. I'll start my engines here. It's wonderful to be here with you today and very much appreciate this opportunity. So Prism Health Group was founded just about 6-7 years ago, and we have not changed our course one bit in that we are one of the nation's only independent pharmacy consulting firms. And we work with plan sponsors across the country, nearly 5 million members under management. We've got about 30 individuals here on staff that are clinicians like Jake here. We've got economists, PBM nerds, ERISA attorneys, you name it, we got it. And we just love getting into the details of all things pharmacy on a day-to-day basis.
Jake, your turn. Give us a little bit of your background.
Awesome. Well, Sally, really great to be with you here today and have this conversation with you and Ryan. So my name is Jake Goll. I'm the clinical consultant here at the Prism Health Group, and I've had the pleasure of working with Ryan and this awesome team now for a little bit over a year and a half. Time has flown, but had a lot of fun since then. I am a pharmacist by training, but hung up the white coat probably about 7 years now to jump over to what they would call the dark side or the PBM side, but have worked my way through a couple different PBMs and a variety of roles with those, and eventually found my way here to the Prism Health Group, where I've had the pleasure of building out the clinical department and Spectra, which we're here to talk to you about today.
Absolutely. All right, so let's start high level. Clinical Performance Engine. Spectra. What is it and what does it do?
Take us to the promised land.
I'll take us off here. So I actually designed Spectra, gosh, it was probably a year ago that Ryan actually came to me now and kind of started having this conversation about how do we build out this clinical performance engine, this clinical performance ethos. I think we had a number of fun terms that we used to describe it right off the bat, but now we just kind of call it by its name, which is Spectra. And so I really designed Spectra based on experiences that I originally drew from the PBM side, and now on the consulting side, getting to work with a variety of PBMs. And so just a little bit of backstory. When I was on the PBM side, I would say I worked with a very solid clinical PBM from that perspective. But one thing that I saw as an account executive is that we still miss things. So my very large client in particular actually had a team of 3 pharmacists that were independent to the PBM. And they really held me accountable and our account team accountable and made me realize some of the things that were really being missed even by PBM's programs. And the truth is, most PBMs are not going to have a pharmacist or a team of pharmacists who every single day are looking over claims data for that clinically inappropriate utilization or these opportunities. And so there's that whole clinical aspect of it. But in addition to that, I think we have to look all the way down to the foundation of the plan itself. And so a lot of times the clinical plan design rules are chosen one time, and then we kind of just rinse and repeat without doing a deep dive year over year and not evaluating potential opportunities in that clinical plan design. And those can have a huge influence on utilization and spend. And what I've really found is that it's absolutely crucial to keep up with those and make sure we're following industry best practices, just to make sure that claims are coming through as we expect them and keeping up with what the market is ultimately wants and what the market needs. So Spectra is intentionally designed as this clinical loop. It's not a linear program, and each component of Spectra kind of feeds into the next. So over time, we're continuously returning to that beginning foundational aspect to reassess, refine, and evolve the plan's clinical blueprint, that really cyclical structure. But to really summarize it here, it's kind of three main parts. We have that clinical blueprint, and then we have that middle part, which is that really extreme pharmacist involvement, doing that forensic analysis of the claims, and we call that precision utilization management and analysis. PUMA is our fun acronym for it. And then the third kind of pillar of that is that retrospective oversight and performance validation. So, we keep up with those clinical points all throughout the year with PUMA. And then finally, at the end of the year, we kind of look at the plan as a whole and say, okay, where do we want to go next year? And how is that going to influence our blueprint moving forward?
I want to take a step back by saying I think a lot of our listeners who are very well educated in the benefits industry would be surprised that this isn't already happening with their PBM relationship. So give me an example of what you might find when you're doing that clinical blueprint.
Yeah, absolutely. And I want to give PBMs credit where credit is due here. I mean, they do an outstanding job of adjudicating claims and creating that criteria and kind of handling the day-to-day aspects of the claims adjudication and formulary oversight, whatnot. But really the goal with Spectra here, and to give a few examples, is doing that forensic analysis to identify those potential, I guess we could call them problem claims that maybe the PBM isn't noticing, particularly in their day-to-day operations. So I'll tell you some of the common ones that we kind of see here. One of them is escalated dosing for IBD products, so inflammatory bowel disease products. And with that, we'll see your drugs that are hitting your top 10 list, like Skyrizi and whatnot. We'll flag those claims where it's coming in at doses over the FDA approved limits or the quantity limits. And with that, it becomes a conversation with the provider. And I think that's the big differentiator here is Prism's clinicians do actual outreach to the provider and say, hey, we noticed this dose escalation here based on patient characteristics and their pharmacy claims data. Here are some potential other therapies that might be a better option instead of escalating that dose, and having that conversation to kind of ultimately guide them to potential therapeutic alternatives that aren't nearly as expensive. Because we know that when we double the dose of Skyrizi, well, that also doubles the cost as well. And Skyrizi, as we all know, that's a very expensive medication at its normal dose.
It ain't cheap.
It ain't cheap. But outside of that, too, there's a cost aspect, but there's a safety aspect as well. And the important thing about the safety aspect, too, is you're avoiding downstream costs with that as well. So one of the things we look for here are cardiovascular new starts. And the way that works is it flags new starts on a drug called clopidogrel. So that's generic Plavix, very cheap medication, been on the market forever. So that drug, it's in and of itself is not really a concern from a cost perspective. But what it's telling us is typically that a patient has had a recent cardiovascular event. So that's prompting us to dig into their profile and say, okay, did we make sure that they got started on all of those appropriate, post-cardiovascular event medications? Do they have a blood pressure medication on board? Do they have a cholesterol medication on board? Making sure all of those appropriate medications are there so we're avoiding, say, a readmission down the road because we didn't optimize pharmacotherapy. And actually, the cardiovascular optimization, anecdotally, take it a step further here. The benefit of having a trained clinician looking at these individual profiles is that we can do kind of a drug disease analysis too. So I'll tell you that earlier this month, I was running through a patient profile and found that they had started not only on clopidogrel, but their provider had started them on a triptan as well. So a triptan is a migraine medication. You think of like sumatriptan or Imitrex. Again, it's a very low cost medication, but sumatriptan, a pharmacist should know, is not to be used in patients who have a history of a cardiovascular event like a heart attack. So immediately red flags are going off. We're saying, oh, we have them starting this medication that's typically started after a heart attack and a medication that's not supposed to be used after you've had a heart attack. So that starts a whole cascade of provider discussions just to make sure everybody's on the same page and aligned and we're having that safe and effective therapy on board.
Prism already has a known name in the industry for your exceptional data, the way you analyze. Why did you decide to get on this path? And what does it mean for a plan sponsor to have pharmacist-led forensic analysis?
It's a great question, Sally. And I think this is something that, when we look at the marketplace here at Prism, we're not here to cast stones, or we're not here to try to pass judgment as to who has the best clinical programs or whose analytics look the sexiest. Our job is to tell a very clear, pure, and understandable story and lend perspective on all facets of the pharmacy benefit. And as a utility of that, I think where a lot of folks fall short is being able to really dive deeply and having a pharmacist in a box, so to speak, like Jake here, in and amongst your pharmacy benefit. It's not to challenge or to be, adversarial with a PBM. And I think Jake said it right off the bat, which is this is not designed to be in conflict with the PBM. And in fact, there are many different kinds of what I would call clinical programs or overlays, whether they're owned by a PBM and they may have their own different incentives, or it could be a freestanding third-party solution. We designed this solution very specifically with the intention that it's not designed to be a gotcha catcher. It's truly to look at a multifaceted view of, yes, economics, yes, absolutely patient safety, but also the overarching performance. And that's really what this comes from. At Prism, we believe in a performance ethos. The days of trying to RFP yourself to savings are over. When we see so much compression in the marketplace around some of the largest of PBMs with some of the regulatory work that's been done at the state and federal levels, when we take a step back, it's important to say that, okay, well, if everyone's getting squeezed, we also have to look at that rag of opportunity and being able to wring it out as best as we possibly can so it's bone dry. And that's exactly what Spectra was designed for. It's to work in tandem, in concert with a PBM, with the plan sponsor, not to be that gotcha, but rather a secondary set of eyes. We're always watching the analytics, the tools, the proprietary infrastructure that Jake and team have built. Truly impressive. And it's designed specifically to be an augmentation of this total picture instead of just an isolated way to drive value, if you will. And it's really done a remarkable job at adding so much depth to the conversations that we are having with clients and to give greater perspective as to how to skate to where that puck is going.
Okay, let's talk about that because, you mentioned the third component of this is a word that actually very few people in our industry are using right now because everybody's talking about proactive data. But Jake, you talked about the value of retrospective oversight that Spectra brings. So unpackage that for us.
Yeah, for sure. And I think it's important to kind of clarify too that there is that proactive component of Spectra, because with this kind of data platform that we've built out, it is run on a daily to weekly basis typically. And with that, there are pharmacist eyes behind all of those data queries as well. So the idea there is, like I mentioned in that cardiovascular example, where we're flagging a potentially unsafe situation. The goal is to get ahead of it before it really becomes a problem. Or with the Skyrizi, the goal is to get ahead of it and potentially get on a lower cost medication before we hit that 1 year mark and say, oh, we've had a year's worth of claims at a dose that's above the FDA labeling, and we spent an extra, $150,000 on it. So from a retrospective lens as well, what we're doing is at the end of the year, we're kind of truing up all that data and have these clinical queries that are designed to unpackage everything over the course of that year. So not only are we looking at the top 10 most expensive categories, top 10 most expensive drugs, we're breaking each individual category down as well, seeing what the top 10 drivers are within each category. And then we'll take it a step further even too and benchmark that against other plans across our book of business and say, is there a particular area where your plan is standing out in terms of cost or utilization? And our data allows us to break that down and specifically say to a drug level why that's happening. And so once we ingest and digest all of that retrospective data, that brings us back to the very beginning again, which is that clinical blueprint. So we say something like, oh, we noticed that there's high brand utilization on your multi-source brand drugs that all have generic equivalents available. Why could that be? And one thing, just as an example that we found is, say, maybe you didn't have your DAW or dispenses written penalties turned on, where the patient has to pay the difference between the generic product and the brand product as a way to incentivize that generic utilization. And with that, we can go in and adjust that blueprint, have that plan design rolled out in the new year, and then the process starts over again. We continuously refine from there.
Okay, we've covered the platform. What have we not mentioned? Because we are getting close to the closeout time. So what have we not covered, Ryan, that you want to make sure we do cover?
Jake, what do you think? I think we've talked about the ethos, the why behind it. Mm-hmm. We could touch on the fact that, again, the specific, I really like the way we talk about why we built this or how you designed it, that it's not just another clinical program, but it can be deployed at any time. It's more around the value around being in concert or lockstep with your PBM. Mm-hmm. If you're a type of PBM that maybe is playing a little fast and loose, it's going to find it. But it's also going to make the best of PBMs even better because you've got another set of objective eyes watching closely. I think that could be a good avenue.
I heard you say earlier that this is not intended to be in competition with the PBM at play. This is certainly not a PBM replacement. Mm-hmm. It's augmenting that. Jake, in the conversations you're having, what does that look like? How does that play out?
Yeah, so I'm working lockstep with the PBM. The nice thing there is, Spectra, we're not coming in and completely blowing up the formulary or blowing up PA criteria. The idea is kind of that smooth, it works within the confines of the PBM because we know it gets very challenging when you try to go in and do something like a formulary disruption or a PA disruption. We know that ultimately that leads to rebates being pulled back or taken away altogether on specific drugs that are being impacted. So with this, the idea is working within the confines of that formulary. You see an expensive medication coming through. One common one that I see is Linzess in the constipation class. So it's a higher cost brand product. A lot of times prescribers may not be aware yet that Amitiza has a generic available at this point, used for the same indication. So again, that's just a call to the provider's office and having that discussion. Hey, there's a lower cost alternative available for this that does pretty much the same exact thing. And they're usually very open to making that transition. And the key point with that is that we find, at least with the PBMs that I've worked with so far, is that all of these products are covered on formulary. It's just the provider not necessarily knowing what all of the alternatives are that are available. So it's really that pharmacist provider interaction there and increasing visibility into all the options that are available.
I think that's a really important point, Jake, that you make, which is very different than a lot of other overlays or programs. They're PBM specific, or it requires a big mass integration movement. Spectra was not designed to be this cataclysmic event. This program works with every PBM without any kinds of crazy gymnastics around coordinating eligibility and all these other little things that, to Jake's point, is going to unravel some of the terms in your contract. It's designed to be able to fit within the constraints of what was agreed upon and to ultimately hold folks accountable and to give them that extra leg up in being able to work mutually feverish towards achieving best practice. That's all we care about. And I think that's all PBMs really care about if they're being honest. And I think that if we're both doing that to the best of our abilities, everyone wins.
Okay, you sold me. Let's say I'm an exceptional plan sponsor that is bought into this. How does it get layered in? Is it a standalone product, platform? Walk me through what those next steps look like.
So Spectra is its own discipline, and with that, what you're getting is an individual pharmacist who works lockstep with your plan, who knows your benefit design in and out, and is on call for your benefit staff for any of the clinical questions that come through. So that comes in addition to all of the data analytics and the extra clinical monitoring, that provider outreach that comes with it. That's one aspect of it. But the goal here too is to really build that relationship with the plan sponsor as well, so that they have the comfort of knowing they have a clinician that they can reach out to directly, who knows how their plan is built and is able to answer those complex clinical questions that are either patient specific or related to plan design and how to proceed with those elements.
Yeah, it's a really good point, Jake. And I think that for those, whether you're a current client partner today, or maybe you're in the market for the types of services that Prism provides, like Spectra, it can really be built in a multitude of ways. Just as it doesn't require any specific effective date to put the program Spectra in play, it really can be layered in at any point throughout the given course of the year. And the other added benefit is that Spectra comes with a return on investment guarantee. We never expect the client to simply, and there's too many solutions that are out there that are saying, wow, I'm going to save you all this extra money. That wasn't the intended purpose of designing this product to begin with. It's about best practice. And it just so happens that cost savings and better patient outcomes, they all follow best practice. And so whether you're looking for Spectra in and to itself as a standalone service where you have a Jake in the box, so to speak, or if you are looking to bundle this into a broader consulting engagement that's really optimized to hit every nook and cranny of the pharmacy benefit, we got a solution for you there too.
I think that's the perfect note to end on. We at the Granite List are so proud to partner with you guys. We love showcasing the work you do. Certainly being able to tell the story of Spectra and its powerful clinical performance engine. So as our audience listens, they can certainly find more at thegranitelist.com, but also at theprismhealthgroup.com. And of course, you all are very active on social media. I know that you have a newsletter that comes out on LinkedIn. So I would encourage our listeners to sign up for that, because it is chock full of valuable information on just PBM oversight in general, and this new clinical component adds a whole nother layer. So thank you both for being here, and thank you for your partnership and your friendship with the Granite List. Thank you to our audience for tuning in to another episode of the Granite List Live.
Thank you for listening to this episode of the Granite List Live. Access our entire library by visiting your favorite podcast venue or subscribe on our site, thegranitelist.live.